morning. Thank you for the invitation. I will try to address the topic regarding spinal fusion in axial pain and whether this is justified. Some introduction is always necessary. So chronic low back pain is defined the pain that is lasting more than 3 months, and it's the most common reason for missing work across all social work. The probability to return, it's negligible. It's after respiratory tract infection, the second most common reason for visit to a physician. It affects pretty much all the population, it's 80%. And in the US, where we have significant statistics, we know that afflicts about 10 million people annually. And the cost is about $100 billion annually, and most of it because of decreased wages and productivity. We think that's what we have in mind, that most of the patients with low back pain have good prognosis, and only 10% will have pain after 3 weeks. Well, this is not really the truth, because low back pain is more complex and have frequent recurrences, and about 30% of the patients will experience moderate or intensive pain continuously or intermittently. And about 20% of those patients will have long-term limitations, so it's more complicated than we have in mind. Of course, it starts with the degeneration of the disc, which is part of the normal aging process. And after the disc, the facet joint will follow. So pretty much it's a cascade of events that starts here, and it ends with facet degeneration and osteophyte formation and stenosis. Well, is all axial pain secondary to degenerative disc disease? Well, not really. There are other also factors such as myofascial pain and things that we don't know. We definitely know that as we grow older, there are symptomatic subjects that have degeneration, have an MRI like this, which is not related to any symptoms, and we can even relate symptoms with degenerative disc disease, even with sophisticated methods such as discography. Therefore, we have abandoned the later. So we are trying to be as conservative as possible, and very cautiously we're moving to the fusion, which is considered always the last option. And when we're talking about conservative treatment, it's education, physical therapy, and patient management. And also in the surgical treatment, there's also total disc replacement. So although we like this X-ray, we always have to bear in mind that this is similar to this X-ray. It's fused arthrosis, very far away from this X-ray. And despite good RCTs on total disc replacement and that are showing pretty much even results or even better, we're still far away from here. So what are the statistics today? We know that spinal fusion is a procedure very often is one of the most common surgical procedures in the States. So from 2004 to 2015, they've seen about 60% of increasing of the rate of this operation, and the hospital costs increased about 180% the last 10 years to pretty much close to $10 billion US dollars. If you see this graph here, you'll see that the fusion rate for spondylolisthesis and scoliosis increased, but the fusion rate for degenerative disc disease has decreased. This pretty much is reflecting the controversy, and and also the fact that the insurance company are not really compensating for the operation. So this is what Blue Cross Blue Shield will pay for. These are the indication. They are not paying for degenerative disc disease. If you see what's happening with other insurance companies such as Aetna, they consider fusion for degenerative disc disease experimental and investigational, so they don't compensate. And Sigma, for example, they are not paying for multi-level DDD, they're paying for single level, as long as you can prove that it's just single level and the patient is not crazy. This has not happened yet here, but it's pretty much will follow. So let's go to the evidence. There are 6 RCTs out there investigating lumbar fusion for chronic low back pain and DDD. This is the RCT from Dr. Fritzl from Sweden, published in 2001, that pretty much convinced my generation to do lumbar fusion in degenerative disc disease. They had 294 patients with back pain that they were following for at least 2 years, and they randomized this patient to surgical and non-surgical group. The surgical group, that were 222 patients, were treated with 3 types of fusion, and they later showed that the type of fusion does not make a difference, versus 72 patients that were treated with physical therapy. They followed them up for 2 years, and they showed that back pain and leg pain dropped dramatically for the first 1 year and 2 years, and in 2 years it remained very low. So after 2 years, the much better group and the better group in the surgical group was about 60 patients, and in the non-surgical group 60% of the patient, and in the non-surgical group was about 28%. Next RCT, 10 years later from Japan, very small number of patients, about 41 patients. Again, they randomized patients to fusion and non-fusion. And the fusion group was ALIF and posterior spinal fusion. They showed that all scores improved dramatically, significantly with surgery at 1 and 2 years post-op. These 2 papers came from Norwegian, from the same author, Dr. Brox. They randomized patients again to surgical versus non-surgical therapy. Non-surgical treatment was cognitive intervention and exercise program. They found no difference in ODI between the 2 groups. And they showed analogous results when the fusion was performed after disc herniation. The criticism in these 2 patients was the low number of patients. There were 60 and 64 patients respectively. The 5th RCT comes from England. About 360 patients, so 176 patients were assigned to surgery and 173 to rehabilitation. In the surgical group, only ODI improved, and there was no difference in other outcome scores. And the authors consider the statistical difference in ODI between the 2 groups marginally, not really justifying the operation, considering the amount of the cost and the potential risk for the operation. The Norwegian group and the British group, they put their patients together later. So very recently they published this paper on 261 patients. So they lost about 45% of the patient, but that was 11 years later. And again, they showed no difference in patients' outcome scores between the fusion and the non-fusion group in patients with DDD and chronic low back pain. So this is not randomized. That was a recent study. That was a systematic review. They review all the literature. They found 26 worth reviewing papers, and in all levels of evidence. And so they pulled together about 3,000 patients. So they had they reviewed the 6 RCTs just mentioned. They showed improvement. They found the total improvement in the VAS score, 35.6 in the surgical group and about 20% in the non-surgical. In the ODI, 29% versus 17.5% in the non-surgical. So with pooled data, they think there is improvement with surgery. They also reviewed the 12 prospective randomized studies that were comparing techniques. So they pulled about 1,400 patients. They found improvement in all the scores, close to 50%. And finally, they put about 6 studies that were prospective, non-randomized, pretty much comparing techniques, all studies, and they showed that fusion is improving, that patients that had fused showed satisfaction about 71%. So they concluded that the body of literature supports fusion surgery as viable treatment option for reducing pain and improving back function in patients with chronic low back pain refractory when the diagnosis of DDD can be made. So where does that leave us? Does fusion have a role? Yes, definitely, but in carefully selected patients. the identification of the right patient is difficult, and the patient really has to fail all non-operative treatment options for an extended period of time. Sometimes we are not really aware of what the patient has done. The patient says that has had physical therapy, but we don't know what that was or what kind of injection he had. So in a nutshell, in my practice, I try to treat only patients with 1 or 2 level disease. They have to be sane. They have to fail conservative treatment that I have supervised for at least 1 to 2 years, and yet I'm still trying to do my best to avoid these patients, although those that I've treated, they do relatively well.